what challenges have you faced as a result of the COVID-19 pandemic that you and your colleagues as PT educators have had to face, have had to deal with in terms of how you educate?
Two major factors. The first one being clinical education, getting the students out into the clinic has obviously been a challenge. And academically, for the didactic portions of the program, it's been, the big challenges have been around lab experiences, teaching the manual skills, the physical skills. How do we do that when they're not in lab with us? Many of our programs are very heavily lab-based for instruction. And since we can't do those, that has been the other big challenge, how to figure out how to deliver and assess the students on those skills when we can't be in the lab with them.
And how do you think you as faculty members have adapted to these challenges?
Slowly. I think we're getting better. I think we're much more prepared for the fall than we were to do it overnight in the spring. We've learned a lot about technology and how technology can be used to have the students videoing themselves practicing skills, and us being able to watch the video and assess and provide feedback. So faculty recording videos of them performing the activity, sending that to students, having students practice it, send us the videos of them practicing, and then letting the students decide when, which is their final submission for them performing a skill, and being able to give them feedback on that. I don't think we can do it for all the things we have to teach, but I think that's how we've adapted mostly, and using simulations for some things, but especially around acute care, but that's been challenging too because we kind of need them on campus for that. So I think that has been the biggest challenge, our lab skills and finding ways to do those distance-wise, primarily using video.
Mm-hmm. And how do you think the resources like virtual PT clinician have played into how you've been able to adapt?
I think it's fabulous because it's a great way, during the pandemic or not, to expose students to a wide variety of patient cases and have them think through our being able to see, sort of visualize the student's thought process because of the way the program tracks what the students do in the program. And students being able to do that no matter where they are, as long as they have internet access. They could do it anywhere and any time. So it's easy to work around when we're doing synchronous lectures online. Students can be doing these cases anytime, and then we can see what they did and still give them feedback, again, on our own time whenever we get to it. So there's a lot of flexibility in using it, but I think it's best. It's obviously best at the clinical reasoning process, but it's also very good for exposing students to a wide variety of patient cases, types and kinds of patient cases.
And a consistent experience across the class.
Right. I can expose all of my students to the same case and know that they've all experienced that same diagnosis, that same patient interaction, the same cultural aspects of a case quite easily.
As you're facing going forward into the fall in an unknown circumstance, I guess, and then going forward into who knows, as the coming years, do you see some of the lessons or some of the applications that you as faculty members have made applying going forward and being used more readily?
Yes, I think so. I think you're going to see some permanent changes to PT education as we get more creative and realize what's absolutely need to know, what's nice to know. I think a lot of the tools we develop during this time will continue and will change the way we educate PTs in the future. We're not going to give up our hands-on completely.
When you helped develop virtual PT clinician, obviously you were responding to something you saw as a need in the education process. What did you see as the need, and how does this program meet that need?
So what I saw as the need is an ability to expose students to a lot more patient cases than we had been able to do. PT is a little bit different. When we send them into the clinic, it's not PT faculty out there with them, they're with clinicians. So carrying what we're teaching them into the clinic isn't as easy as in nursing where faculty go with them, or pharmacy when they go with them. So being able to expose students to a lot of cases, to build illness scripts, to start chunking their thinking together, take all that basic science knowledge and give it a clinical context. You know, we didn't have a way to do that. We were doing that with paper cases. And the big limitation with the paper cases is that you were giving the students information. They didn't have to decide when information was needed, what questions did they have to ask, what tests and measures did they have to do. It was, you know, you had no choice but to sort of give them the information. So the virtual patient cases allow you to expose students to a lot of cases and give them very minimal information that is very similar to what they're going to get in the clinic. Patient comes in and says, my shoulder hurts. And that's all they volunteer. And that's the same way in these virtual cases. So the students have to be able to decide what information do they need to know and how do they go about getting it.
And then as a faculty member, what do you see as the payoff, I suppose, of this as a faculty member?
So the payoff for me is that we really have no way to assess clinical reasoning. We really don't have any way to even understand how well a student is reasoning through a case, other than by talking to them, and most of our class sizes are too big to allow us to do that. So the virtual patient program allows me to do that because the students working individually, I get feedback on their reasoning process. I can see what they did. I can see where they missed things, where they were really good at other things. So, and then I can give them individualized feedback on that, and hopefully the next case they do, they correct whatever issue I saw in the first one, and I can help them move their clinical reasoning along and improve it. I had no way to do that before because, you know, you're usually doing a case in a group, and as always, when you work through, the stronger students are speaking out, the quieter students are not. This doesn't allow the students to not reason through a case. Everyone's doing it individually. So I love being able to give individualized feedback. I think that's super important for clinical reasoning.
Mm-hmm. And the role of debriefing in this whole process. Tell me a little bit about how you approach that and the importance of it.
So I love the debriefing, and the debriefing is after the students do a case, I look at how the class did, and I look for trends that, you know, either the majority of the class did do this or didn't do this. And then I go back to them and I ask them about that. I noticed that half of you didn't put pain on your problem list. Do you think pain is a problem for this patient? And of course they're all saying yes. I'm like, okay, why did you not consider that something you needed to put on your problem list or intervene on? And then we have a discussion around why. And some of the answers are great. You know, well, I assumed once I improved their strength, their pain would go away. And that's legit. So it turns into a really nice conversation about how they arrived at whatever they arrived at, you know, and then we can have a discussion about it. So it's very, very much a discussion. It's very back and forth. It's very low stakes. It's not, I don't find the students get defensive about their answers or their justification as long as I ask in a very inquisitive way. You know, I kind of ask, what the heck were you thinking, in a nice way. And the debriefing is really fun because I find sometimes that what I expected them to do, they didn't do, but they had a good rationale for why they didn't do it, which is acceptable and very, very true to clinical practice.
Our founder always said, get inside the students' heads.
Absolutely. And that's the best part of this program. That's what it lets you do. I can see what they were thinking. And if I can't tell what they were thinking, I can see enough to go back and ask them, what were you thinking at this point? You got this piece of information. You kind of didn't do anything with it. Tell me why. You know, why didn't you? Why didn't you think that was important? So it's a really great way to also get the students to talk about their own thought process.
And if there's an error, then you can correct it before it shows up.
Absolutely.
You know, I know that you and your colleagues face a lot of pressures with time. How do you maximize the learning outcomes from these kinds of experiences that you assign to your students?
So obviously I'm very comfortable with the program, but I find when I first started using it, especially, the program has a nice option to do individualized feedback or group feedback. You can look at the class trends as a whole. And that's a great way to start. It's not time consuming. You could look at those class trends in a few minutes, and you can look for big issues that the class either got or didn't get, and just debrief on those things. And you're still going to make a really nice improvement. It might be that they misunderstood a concept that you thought you taught really well, or you realize that you didn't make this very clear to them, or you don't know why they didn't do that, and now you can go back and ask them. So it's really nice to just do a debrief with the class and see how the class trends were. We often find this, we find this very commonly. There's a patient case that is 2 days post-total hip replacement, and the students all prescribe a walker for the patient. None of them assess upper extremity strength. So none of them ever determined, does she have the strength and the hand strength to use a walker? And as soon as I say something like that to them, I'm like, how do you know she has the strength to use that walker you just prescribed? And they're like, oh, we should have checked upper extremity strength. Right, so those are common things that really easy to see and make those connections for the students. When they miss things like that, that's a simple correction to make, and then they never miss it again.
Yeah, I would think that they would remember that.
They do. They do very much. Yeah. Yeah.
I think the whole concept of learning through a story, people remember stories.
Exactly. Exactly. In the same case, she had the hip replacement because of arthritis. Well, she also had arthritis in the other knee. And they also don't think of that. They get so focused on the hip, they forget she has arthritis in other joints. And I can talk them through them. Like, where is she putting all that weight now that she had her right hip replaced? And they're like, on the left leg. I'm like, and how's that left knee? And they're like, oh yeah, she's got arthritis there. Those are the kinds of connections that are so easy to make for them in programs like this.
Teachable moments.
Yes, absolutely. They're huge. They're huge with this program.
So if you were talking to a faculty member who wanted to start learning about virtual PT, how would you sum up what the program is and does? And then I'm going to ask you about one of the you as a power user, how you approach it.
So if a new faculty member was using it, I would encourage them to pick some of the cases that are already written. There are how many, 20, 25, 30 cases already written, to take one of those. And we have cases that are written for first year students that, with low expectations of what we expect them to be able to do. And I would start there. The criteria are already set up, but if you wanted to change a few of them because you hadn't taught something yet, you easily could change that. And I would start there, and I would start with giving them, a single case and doing a class debrief, just looking at that class feedback and doing a debrief based on that. And then I think once you did that once or twice, then I think you'd want to know more, and you'd start looking at the individual, or you'll see that there's consistently one individual in the group who doesn't do what the rest of the class did, and then you might want to give feedback to those few students who you can see were really not around the class averages. That's how I would start using it, and I would start using it very early in the curriculum. We use it in the first class they take in the curriculum to get them thinking like a PT early. So yeah, for a new faculty member, someone new to it, I would use the cases we already have and do class debriefs before you get into the individualized feedback.
And then you as a power user of virtual PT, I'm sure that because you're the, it was your brainchild. And because you've been using it so consistently, you have some of these pro tips that might help someone. What's one of your best pro tips? When I go to look at a case, I will still go to those class statistics. And when I see a criteria item that I wanted them to do and they didn't do it, I can click on that and it'll tell me which students didn't do it. And I will look consistently to see which students aren't doing the things that I want. And then I will give them individualized feedback. I like to give individualized feedback to everybody. But when I first start a class doing the cases, I do the group feedback, and then I move into individualized. And I've learned what the program grades for me and where I really need to focus, which is usually on the goals, because the program doesn't grade the goals.
And I've gotten very good at, when I write the criteria, what I want them to put on their problem list, of using synonyms. So like, I know how a student tends to misspell tendinitis. So I would put that in the synonym list. So I've gotten very good at, for both the problem hypothesis list, of putting the words students commonly use, so that the computer is more effective at self-grading, the program's more focused at self-grading. Then I can very quickly go through those categories. And I can very quickly look at what history or exam items the students didn't do. So by doing those things now, I can now grade an individual record in, under 5 minutes. So for a class of 40 in an hour, I can go through all of them.
A lot faster than a paper case.
Yes, and with so much more information. And that's with me typing them. The software allows me, especially when I look at their goals that they wrote for the patient, to give them individualized feedback on their goal writing, which is something I think a lot of PT students struggle with. And I can very quickly give them feedback on that. So even with doing that, I can still do, 45 of our students in an hour.
When you're telling other faculty members about what this program is, what do you say to them? How do you sum it up in, quick summary?
You get in the student's head. You get to see what's in the student's head. You get to visualize their clinical reasoning process. And that's usually enough, because faculty know we have no way to do that. There isn't another good way to do that. So to me, that's the key. That and the individualized work, the students being able to, making them do their own case. And then I usually talk about, how unrealistic it is to give them a paper case where we're feeding them information.
Right.
Like, that's not how it is in the clinic.
And this is one of the very few programs designed specifically for PT education.
It's the only one that I know of. I've seen some other patient simulations, but they're basically just taking a case and acting it out. It still doesn't have the power of letting you see the reasoning process that virtual PT has.
As you see the evolution of PT education and this program, how would you see this advancing PT education?
I think mostly in the area of clinical reasoning, which is one of the big areas we all struggle with. And we know that, a new clinician is still not good at clinical reasoning. There's a good 5-10 years of clinical practice that needs to happen for them to get good at clinical reasoning. I think this program allows us to shorten that gap. And I think they can be better at clinical reasoning when they enter the clinic. And I think it makes the process more explicit for the students, so they understand the process better. So I think it will change that way. And how I'm going to talk to my faculty about it when they come back on Monday is that it's a great way to expose the students to more cases and to use the video components, use the heart rate, ECG, EMG, all the things, the media we can put into the virtual cases to make the cases more realistic. I think they could be used, for skills checks and for OSCEs and things like that. So I'm going to be pushing my faculty to do a lot more of these cases, since we aren't going to have the students in front of us as much, and that I can't grill them. I can't ask them why. Tell me why. Tell me why. This program allows me to do that when they're not in front of me. I'm actually kind of excited that I'm hoping more faculty will spend time getting to know this program, because I think it will really help as we do more distance education. I'm hoping more faculty will realize the power of it.